Good day, everybody. My name is Tony Lai, and I'm the senior pharmacist in antimicrobial stewardship at the Children's Hospital at Westmead, and I'm also a clinical lecturer and PhD candidate looking at AmberZone therapeutic drug monitoring. It really saddens me that I can't be there in person to share with, to talk to you in person, and to be able to network with you and some of our American colleagues today. But nevertheless, I thank you for the opportunity to speak to you all today. And I'll be spending the next 30 minutes talking about pediatric clinical pharmacists in Australia and what that looks like. So the overview of today's talk is I'll be going over quite broad in broad big picture stuff with pediatric healthcare, and then focusing on my institution, the Children's Hospital at Westmead, and then going back again to pediatric pharmacists, looking at networking, society credentialing, the references we use, and pediatric research that is currently occurring in Australia. So, pediatrics in Australia. So Australia is a population of around 25 million now, and 1 in 5 of those are children. So over 4 million children in Australia, and 1 in 3 of them live in New South Wales, which is the state that I live in and our hospital is servicing. And then most of the other children live on the eastern seaboard near the water in Victoria and Queensland, and all mostly in metropolitan areas. Compared, looking at the deaths per 1,000 live births in the countries that report data to OECD, surveillance data, Australia performs quite well. And over the years, our infant mortality has improved. What's quite stark or specific to Australian healthcare is that there is a big difference in infant mortality or child mortality between the Indigenous Australian and the non-Indigenous, almost twice the mortality rate. And this is also consistent with children living in more remote areas or of poorer socioeconomic. So the top 3 causes of death in children aged between 1 to 14 years is injuries. So these are the most common reasons for admission too, is injury, cancer, and disease of the nervous system. Now, as we look in to the adolescent age group, what is most contrasting is how mental health is a significant issue, attributing to 1 in 5 deaths of adolescents. So this is why there's a large drive in funding in mental health in Australia and research and development. So how many children's hospitals are there in Australia? There's 8. This is just consistent with, I guess, the earlier slide showing that where most children live. And this is me here, the Children's Hospital at Westmead, and we are the largest tertiary teaching hospital in Australia. Still much smaller than the hospitals in Vietnam, admittedly. But we're around 350 beds, and we're a state-funded public facility with a 40-minute drive from Sydney City. Now, we are waiting for a bigger, fancier hospital coming in 2025, just to support the growing population in Australia, certainly in the western suburbs of Sydney. And this is our new emergency department and what our new ward's like, which is quite exciting and not too far away. Now, our current emergency sees over 50,000 presentations a day, and of those, 6 out of 10 are seen within 4 hours, which is a key performance indicator that we use in Australia to compare the performance of emergency departments. And 1 in 3 of them are admitted. Now, we do have a full PICU, NICU, and short stay wards to help with the bed block. And also we have quite a comprehensive hospital in the home service whereby nurses administer IV antibiotics for in the patient's home for numerous indications like endocarditis, pneumonia, UTIs, which helps helps with the patient flow. And more recently, we've had a lot of funding to support outreach and virtual COVID wards. Like during the peak of the COVID pandemic in Australia, we had over 1,000 paediatric patients looked after by telehealth, by a nurse checking on them every week and whether or not they need to be escalated for severe COVID treatment. So these are the type of services that we provide at our hospital, and this is not too dissimilar to other paediatric hospitals around Australia. So quite a comprehensive service of surgical and medical, including burns and trauma and neurosurge. Now looking at our pharmacy department, this is kind of the organisational chart of what a typical pharmacy department is, and this is what my pharmacy consists of. We have our director of pharmacy at the top, a deputy director, our number 2, and then 12 senior pharmacists who generally manage a specific specialty area. And then under that we have all our junior pharmacists and rotational pharmacists, our specialist pharmacists that are mentored by the senior pharmacists, and we also have 2 pharmacy graduates. So these are pharmacists that are freshly out of university, freshly graduated from university, and there are requirements for their registration to do 12 months of supervised practice. So it's a good teaching opportunity for these pharmacy graduates, which are very competitive positions to hold. And we also have pharmacy technicians and assistants, which are worth their weight in gold. And every few weeks we have pharmacy students we teach and mentor. This is the front of our pharmacy department. This is our inpatient and outpatient pharmacy dispensary area. This is our compounding non-sterile area. So this is for all the medications that are not age appropriate and when there is no age-appropriate licensed product, and we have to fill in those gaps by making our own suspensions, for example. This is our TPN pharmacy, our oncology compounding unit, and going straight into our pharmacy expenditure, we spend up to 150 million Australian dollars every year in our pharmacy budget. So that's strictly looking at what is dispensed through our pharmacy medication use. Now the top 5 most expensive in terms of total expenditure are our TPN, including our home TPN and custom TPN. AmBisome, because we have a large hem-onc BMT unit where we use AmBisome as our empirical treatment and prophylaxis. And then we got infliximab and adalimumab, which are your monoclonal antibodies for autoimmune diseases, which are very costly, and defibrotide for veno-occlusive disease. Our Westmead Children's Hospital is an entirely paperless hospital where we have electronic medication management system. We use Cerner PowerChart, which has all the medical notes, which I show you screenshots of, and where the medication is charted and the nurses use to administer it. All our pathology reports are there, and it's integrated well with our dispensing software. We use iPharmacy, which is actually an Australian product, and the staff are well integrated using Wi-Fi and working from home via VPN, especially during the COVID pandemic. And our workflow is heavily pager dependent, with quick access to Microsoft ecosystem using emails and Microsoft Teams for our meetings. This is a screenshot of our electronic medication management system. So this is Cerner Power Chart. Here we've got all the progress notes documented here on the right, and this is a patient profile that you would open up, and you could go through all the medications this patient is on, and this is where the nurses would use this to either request medications from the pharmacy or to record the administration of. So looking at the prescribing workflow here, we've got our doctor, nurse, and pharmacist with our patient right in the middle. So our doctors will prescribe according to our local guidelines and policies, and our formulary options. So our formulary, because we are a state-funded facility, we have a specific list of medicines that is appropriate for our patient cohort, and then we have EMM power plans, which I don't have time to go through today, but basically it's a bit of clinical decision support for our doctors to help prescribe appropriate therapy and order right bloods. For example, sepsis power plans, where it has the list of antibiotics according to their focus of infection, the type of bloods they need to order, and the OBS. And then when the medication is charted, that's when the nurse wants to administer, and they can access the medications either on the ward in their ward cupboards, which we call Impress, which is a designated list of meds that of heavy use according to historically on that ward. For example, it could be a cardiology ward that has a lot of antihypertensives, or a surgical ward with all the analgesia. And recently we've adopted ADCs. These are little computers, or automated dispensing computers, which help facilitate this. But if these medications aren't on the ward, this is when they put in a med request on Power Chart, and that sends a request over to the main dispensary, which I had photos for previously. And that's when pharmacists can review those medications, or they could just review what's on the medication chart in the comfort of their own office. So pharmacists are involved in clinically checking the appropriateness of that medication, right dose, right product, administration, dosing advice, and for those that are med requested, we do a product check, so we label it and send it up to the wards. For those that need compounding, that gets done either in our aseptic or non-sterile compounding pharmacy labs. Sometimes we need to source these medications. There may be patients who are discharged in hospital or home, where we would organize infusers that are 24-hour infusions for these patients. And we act as the police officers for really drug committee governance, whether or not the prescribers are prescribing according to guidelines, according to approved indications, whether or not they're prescribing a drug that is on our formulary. If it's not on our formulary, we would follow that up with the paperwork for either addition to our formulary or an individual patient use. We will just order that one drug for that one patient specifically for this admission. And then antimicrobial stewardship governance, which I don't have time to go into now, but it's basically ensuring that it's appropriate prescribing according to restriction policies. And it's an opportunity for clinical pharmacists to enact therapeutic drug monitoring. So if patients are admitted or discharged out of hours or from emergency or even our outpatient clinic, these scripts can come to our pharmacy or to community pharmacies, so pharmacies outside this hospital, and these are where the prescriptions would be federally subsidized under the pharmaceutical benefits scheme. So that's a list of medications that the federal government are happy to subsidize according to health economic benefits. Now, these are the drugs that we have available for therapeutic drug monitoring at our institution. So we've got all our antimicrobials, vanc, teicoplanin, or gentamicase, Tobra, all our azoles, and recently we've started doing isavuconazole TDM, all our beta-lactams, and linezolid and ciprofloxacin. So here's a long list here, and we've got a comprehensive list of immunosuppressants, and also paracetamol as a common drug for overdose in our adolescents. So for two of our drugs, vancomycin, tobramycin, and even sometimes amikacin or gentamicin, we use Bayesian forecasting, and we've subscribed to DoseMe, which is an example of Bayesian forecasting software available, which has all its benefits, which I can go through a bit later. But the beauty of it is that you can take levels that are non-steady state levels, non-trough levels, and use patient-specific covariates like patient's creatinine, age, sex, and weight, and it would give you a more accurate dose recommendation compared to just trough-based dosing. And we've looked at that locally, which is all kind of pre-published, peer-reviewed at the moment, but we are looking into it. We're just waiting for a longer observation period. But basically, we've noticed that Bayesian forecasting guided dosing is more effective at achieving therapeutic levels, so less patients having high vancomycin levels above 20 milligrams per litre. Michael Neal is one of the first who does these fancy violin plots, looking at pre and post AUC monitoring in adults, and we're trying to show that in our group. But I guess the most important thing we're showing is not just PK endpoints, but clinical endpoints. And this is a busy slide, admittedly, but it's just showing us when we change to AUC monitoring, and we've noticed a significant drop in our vancomycin-induced kidney injuries. So that's defined as a creatinine that's doubled within 48 hours of starting vanc, and an attributable vanc level that's above 20. We used to get 1 to 2 a month, and that's dropped quite significantly since we've implemented AUC guided dosing. Now, going on to bigger picture pediatric pharmacy in Australia aspects, networking. So we have the Society of Hospital Pharmacists of Australia, which has over 5,000 hospital pharmacists, and we have a big annual conference generally at the end of the year around November, which is a great opportunity to network with other hospitals of a range of specialties, and each state has a monthly education session, and once to twice a year we run education seminars, and we have foundational advanced seminars in pediatrics that generally get around 100 to 200 attendees every year. We do have a standard of practice document that we're in development, so that's just a nice little 2 pages showing what a pediatric clinical pharmacy service looks like, and the prerequisite skills and knowledge. And we have an opportunity for all the pediatric pharmacists to throw their own queries out and questions out, or seeking help in the various interest and practice groups, which is basically a nice little email forum of, I've got this complex neonatal patient on I don't know, amikacin, and is on renal replacement therapy and ECMO. I got this level. Can anyone help me with this dose? So it forms a nice little network of learning and mentoring too. In terms of credentialing, the SHBA has 2 main forms. We've got the foundational residencies, which is a 2-year program, and that can that can progress to advanced training residencies, which is also a 2-year program more targeted at the pharmacy clinicians who've got more experience in that area and they want to truly specialize in pediatrics as one of them amongst a large range of others. Now, in terms of Australian paediatric references and texts, we've got quite a large range which is accessible to all clinicians in Australia. Locally, we've got our Meds for Kids, so that's our hospital one, and Paediatric Injectables Handbook. But then we've got the Australian Medicines Handbook that's specific for kids. The Royal Children's Hospital in Melbourne has also more information on drug dosing, specifically looking at NICU and units around Australia. We have the Australasian Neonatal Medicines Formulary. And then the SHBA has produced this nice little book called the Australian Injectables Drug Handbook, which really is a bit adult focused, but it does have some pediatric content on there. And then what we consider as the Australian consensus guidelines is the therapeutic guidelines, which has each organ system and a lot of pediatric data guiding appropriate treatment from a whole range of indications. And lastly, we've got our Australian Immunisation Handbook, which has our national vaccination schedule and a lot of important information on vaccinations for clinicians on the front line. So when drug guidelines fail, what do we do? So this is a photo of our ECMO unit in my ICU with my ICU pharmacist in the background. But I just really wanted to show how the complexity of dosing in children is very challenging with a lot of evidence gaps. And this is an ECMO unit, so extracorporeal membrane oxygenation. It's a life support system which really delivers oxygenated blood to our pediatric patients. But I want the audience to really appreciate the opportunities for the drug to sequester in this device. So blood is pumped in and out through this patient. So this is hooked up to the patient with this input here and this pump, which looks like this inside. So it almost looks like a little car turbo unit where this fan levitates magnetically, spins the blood through an oxygenator, and also the oxygen is hooked up to this system which warms the blood. So this is unused. So after a patient's been on ECMO and you look at this unit, it's all stained red. And really you can appreciate how there's opportunities for drug to sequester in all this apparatus, especially lipophilic drugs, but also when you're hooking this up to a neonate, their volume of distribution increases quite significantly. So even hydrophilic drugs are affected. So rule of thumb is that the patients or neonates, pediatrics on ECMO units should be on higher doses. But there's a big evidence gap in the literature, especially in these populations. And I'm very proud to say that we have Michelle Cree and Jason Roberts, who's one of the rock stars in therapeutic drug monitoring space, especially in the critically ill patients. You'll see he has hundreds and hundreds of publications in this space. But Michelle Cree is currently doing her PhD looking at critically ill pediatric patients on ECMO and renal replacement therapy. And these are other opportunities of research that pediatric pharmacists are involved in. So we've got this VANCAP that we're trialing in NICU patients. So this is PK modeling data from our NICU patients specifically, and Bayesian forecasting empirical dosing, so first dosing, based on our local cohort. We have recently got a manuscript accepted looking at dose-me versus using equations for tobramycin AUC monitoring in our CF cohort. We have colleagues at Queensland Children's Hospital looking at beta-lactam TDM in children, especially in the critically ill space. We've got grants looking at Solari, voriconazole and fluconazole point of care TDM, and also looking at IV to oral switch of antibiotics as a control before and after study, and some grants looking at more RCDs in TDM and actually cytochrome P450 genotyping for voriconazole dosing. At Westmead Children's Hospital, we've started to look at how accurate is the bedside Schwartz formula in estimating the EGFR in children, because this formula really permeates throughout all pediatric pharmacy care, where it's used as the formula to assess a patient's renal function and dose adjust meds accordingly. But what we find locally, comparing to radioactive labeled isotopes of DTPA, of over or around about 800 pediatric patients, is that it tends to overestimate GFR, and we've developed our own little correction factor, our own K factor, using like another more modified Schwartz type of equation, and it has improved its accuracy. So this is all preprint, which is really quite exciting. And lastly, we're moving into quite novel treatment options. Westmead Children's Hospital is one of the first, or if not the first, pediatric hospital to have successful cases of the use of bacteriophages in multi-resistant infections. So here we've got a patient here who's got, this is our first case, so this was a poor six-year-old girl who had a multi-resistant Pseudomonas, where we use bacteriophages. So this is a specific phage, a specific virus that infects the phage, and we were successful in preventing her from having an amputation in this case. And this is published recently and made a lot of fanfare. And as a result, we've had a lot of funding support for Phage Australia, which is a new centre of excellence, really trying to improve the access and evidence base for phage treatment around the world and in Australia. So thank you so much for your time. I know it probably feels like a lot in 30 minutes, but it's such a broad topic, and my specialty to heart is ID, AMS and TDM, and I know that we've got esteemed colleagues here speaking, especially Jennifer Lee, who I'm a big fanboy of, following her research, especially in the vancomycin TDM space. So I am keen to network and chat more during the panel discussion. So thank you so much for your time.